So we'll wait a minute as people start joining. Welcome to our CTSI Translational Tuesdays. This is a new webinar series that we have created at the CTSI to highlight some really ongoing kind of work in progress and innovative work addressing COVID-19. And as you know, those who attended last time, when we had in the middle of a lightning storm, we had some technical difficulties, and there could be some today too, so bear with us. But the webinar is being recorded, so others can look at this later. And remember, it is a webinar, not the usual Zoom conference that you've been attending quite a bit of, and that questions are in the Q&A feature, and then we try to deal with them towards the end. We also have a poll at the end that we'll ask in terms of your feedback on this conference. So it's a brand new conference that we're happy with. I think this is about the 6th Translational Tuesday conference we're doing or so. And happy to bring this to you from the CTSI. My name is Dr. Ralph Sacco, and I'm director of the CTSI. Why don't we go to the next slide? So it's really my pleasure to introduce two great speakers as part of this special Translational Tuesday event. So first is Corinna Levine. She is assistant professor of rhinology and skull-base surgery in the Department of Otolaryngology at the Miller School of Medicine. Dr. Levine is also one of our Miami CTSI KL2 scholars and a past pilot award recipient. So it's really a pleasure to have her presenting this work. And she's accompanied by Nisenbaum, who is a T32. He's the third T32 postdoctoral research scholar in the special T32 in ENT, and a second-year resident in the Department of Otolaryngology, head and neck surgery at the University of Miami. So the two of them are really going to be talking about a really kind of interesting and novel approach, smell and taste loss in COVID-19. And they've been working together to describe how multiple independent clinical observations of early smell and taste dysfunction in asymptomatic COVID-19 patients was translated into a collaborative international research. And in addition to summarizing their findings, they'll describe their future research directions and the important clinical applications of their work. This is really an exciting way to think about early detection of COVID-19. And so it's really a pleasure to introduce them. And so we'll get started. Remember, questions in the Q&A box as you go along, and we'll handle them at the end. Dr. Levine.
Okay, well, I'm going to introduce the smell and taste loss in COVID-19, and we're really talking about the translation of clinical observations into collaborative research and clinical application. And I think one of the most important things is to talk a little bit about the background of that COVID-19 timeline. I'm not a virologist, and I'm not going to claim to be one, but I think it's just good to keep this in mind as to why this topic is really important and why we're interested. So the timeline of symptom development and infectivity is listed here. So on day 1, you get an infection, and then as you move forward, sometime, usually between days 4 and 7-ish, you have symptoms that will begin. Those symptoms can happen anytime in that first couple days, sometimes in that first third day, moving all the way to second week, and sometimes even after that. But the reason that it's important to know when those symptoms begin is because when you're infectious doesn't always match when your symptoms start. And so as many of you probably know, you can become infectious within 48 hours of getting the virus infection. It doesn't mean that you have to wait till the symptoms start for you to be able to pass the virus along. And one of the reasons that this is important is because the best probability of an accurate PCR test is really 3 days after your symptoms start. So if you start your symptoms on, let's say, day 6, as I've marked out here, you don't start noticing or being able to really detect that thing accurately by a PCR test until day 9. But you've probably been infectious for about a week. And yet, even with good PCR tests, good technique, and so this is a real challenge for us because we're trying to reduce the spread. So what we're all looking for is early indicators of disease and asymptomatic identifiers so that we can try to figure out who those people are who have this disease before the limits of when we're going to be able to detect it by a PCR test. So I'm going to give a little bit of background, just talking about viral smell and taste loss so that we all start on the same page. So viral infections cause smell loss, and that's pretty common. Rhinovirus, influenza, common cold, that can be a big cause of smell loss, and usually it's temporary. So if you look over here in the schematic, you can see that you get some airborne odorants. They get up into this area in the olfactory cleft or the smell cleft, which is sitting in your ethmoid sinuses. And then they stimulate the neurons, and the neurons actually go intracranial. So they're going to go up here intracranially and stimulate your sense of smell. Similarly with your sense of taste, you have food chemicals that will come and stimulate these taste buds and also go and contribute to your taste function. And remember that these are really connected. So your sense of smell and your sense of taste are pretty well connected. And so sometimes that's why you can feel like you can almost taste something that you're smelling. In the acute phase of a viral infection, you often get a self-limited loss in smell or taste, or both. And frequently we think that's due to nasal and sinus inflammation, and I'll talk more about that in a moment. And occasionally this will persist, and it's assumed that that might be due to injury to the olfactory nerve, but really the mechanism of that is not incredibly well understood, and it's hard to predict when people will develop that loss versus recovery. So if you think about your normal smell, you essentially have odor molecules that reach your smell nerve. So these little odor molecule schematic that I've shown here, and they all pretty much go through and waft up into this area near where your smell fibers are. And that will stimulate your sense of smell, even getting down into your tongue. And that develops your sensitiated, smell and taste. So then in viral inflammation, the nasal and sinus mucosa get swollen. And so if you look down here at the schematic, this is looking at a patient or a person straight on. These are some of the structures inside your nose called turbinates, looking both from the side and then on straight on. And if these swell, then this can start blocking the nose, blocking the ability of those odor molecules to get in and causing nasal obstruction. And that will also block your odor molecules from getting up into those areas where they get into the olfactory cleft and cause that sense of smell. And we also think that sometimes that inflammation happens in and around the olfactory nerve fibers as well. And again, not incredibly well understood, but something that happens during viral infections. So what happened with COVID-19 is that physicians began reporting that smell and taste loss was present in COVID-19 patients. This started in China, but then also started being reported in Europe, in a number of countries, and then in the United States. And so why is smell and taste loss important in COVID-19, since I just told you that it's a pretty common thing that happens in viral infections? Well, the reason that it's important and why we're talking about it and studying this is because what happened was that asymptomatic patients, so patients who didn't have COVID-19 symptoms, started presenting with smell and taste loss. And at some point, many of these patients got tested and they were COVID-19 positive. So this started people thinking, hey, is this an early indicator of infection? Once they started seeing this over and over. So this is where we really needed to get some objective data to evaluate these clinical observations. And so what happened next is international collaborative research, where we got multiple countries to work together to pool our resources so we could pool the clinical data to objectively assess smell and taste loss in COVID-19. And so how we took those clinical observations and were able to translate that into research, Dr. Eric Nisenbaum is going to go through that process with you.
Okay, thank you, Dr. Levine. Okay, so I'm going to talk a little bit about both our own study, this international collaboration, as well as some other data from the literature, both about the clinical characteristics that we know about this smell and taste loss, as well as kind of some early research into some of the physiologic mechanisms that may underlie it. But first, I just want to give some definitions, since you're going to hear these words a lot, and I think there can be some confusion between them. So smell and taste dysfunction can kind of be divided into three groups. So for smell, as you have anosmia, which is a complete loss of the ability to detect odors, as well as hyposmia, which is a decrease in the ability, and dysosmia, which is a distortion of smell perception. Likewise, with taste, you can have either a complete loss of taste, which is agousia, hypogeusia, which is a decrease in taste sensitivity, or dysgeusia, which is probably the one you hear most frequently, which is a distortion of sense of taste. So with that out of the way, Dr. Levine covered this already a little bit, but I just want to talk about the timeline of kind of what happened. So really, we've only known about smell and taste dysfunction in COVID for about 2 months, as the first anecdotal reports started coming out in early March. So as more reports came out, the main ENT professional organization in the UK released a position statement saying that based on kind of early data, smell and taste loss may be a marker of COVID infection. So the very next day, the American Academy of Otolaryngology basically endorsed adding anosmia, hyposmia, and dysgeusia to screening tools and created their own screening tool on their website where physicians could report patients with COVID who were experiencing these symptoms. So the ENT field was actually a little bit ahead of the curve because it took another month for the CDC to add loss of taste and smell to their guidelines of COVID symptoms. And similarly, the World Health Organization then added as well at the beginning of May. I think part of the reason that ENTs were a little bit ahead of the curve on this is because, along with neurologists, we're probably the specialty that deals most frequently with smell and taste dysfunction. But I think another part of it was, a lot of the early reports coming out of China and Italy were that there were very high rates of healthcare worker infections and death among ENTs, even compared to other specialties. And I think part of it, is high-risk procedures, but also part of it is what Dr. Levine mentioned earlier, which is that you were having these patients who were otherwise asymptomatic with this previously unknown symptom of COVID, who, they have a loss of sense of smell. So who do they go to? They go to an ENT. And then subsequently, ENTs and other staff in the offices were getting infected because no one knew to take precautions because no one thought of these patients as COVID patients. So with that, I want to talk a little bit about what we've been doing here at Miami so far. So I think we were a little bit ahead of the curve in part because of some international collaborations we already had ongoing. So Dr. Liu, who has kind of been spearheading all of this sensory research, has had a lot of Chinese research fellows and international observers over the years, many of whom are now ENTs at various academic institutions in China, including in Wuhan. So, when there started being the initial COVID outbreak in there, they reached out to us in early February regarding some of the research they were doing, looking into the protection of healthcare workers and trying to minimize infection in healthcare workers. So we kind of started working with them on that, and you can see here on the right 3 papers we published more on those topics. And then so as data started to come out about the smell and taste dysfunction, we were well positioned to get studies started on that. So we immediately added smell and taste screening to the intake screening that was already going on at all of our clinics. And then using this preliminary data we already had on healthcare worker protection, as well as some of our background in looking at sensory disorders, we applied and got one of the COVID Rapid Response grants, which then provided the resources necessary for us to participate in this multinational collaboration, but now also to begin some projects at which Dr. Levine will talk about. So this is our international collaboration, and there's a collaboration between us, 3 different hospitals that were COVID designated hospitals in China, as well as a hospital in France and a hospital in Germany. So between those 5 tertiary care centers, 394 PCR positive COVID patients were screened retrospectively, and any patient who had any subjective smell or taste dysfunction were enrolled in the study, which ended up being 191 patients, which at the time was one of the largest of these smell and taste dysfunction studies. And then we collected data looking at patient demographics, COVID symptoms and severity, the temporal onset of their symptoms and characteristics of their taste and smell dysfunction, as well as kind of the overall outcomes of these patients. So first, I'm going to talk about the general outcome measure, which is rate of sensory dysfunction. So in the green is patients who had smell dysfunction only, orange is taste only, and then gray is both taste and smell dysfunction. So there's kind of 2 main takeaways here. First, that isolated taste dysfunction is pretty rare, that most patients either had smell dysfunction or combined, which I think could reflect something that Dr. Levine talked about earlier, which is that your sense of taste is very tied up in your sense of smell. So it's possible that at least some of these patients didn't have true taste dysfunction in the sense that something was wrong with their taste receptors, but really they were perceiving olfactory dysfunction as issues with their taste. But secondarily, as you can see, that there is pretty significant differences in the rates of sensory dysfunction between the different centers. ranging from like 33% in China up to almost 70% in Germany. And I think part of that is being a retrospective study that, you know, different centers had different criteria in evaluating these patients, but as I'll talk about a little later, might actually also reflect some true differences in epidemiology and viral strains in different regions. So next, patient illness severity. So this is a measure of how severely ill overall these patients were, which ranges from mildly ill patients who basically just had, you know, in addition to their smell or taste dysfunction, perhaps a little fever, some muscle aches, all the way to patients who are critically ill with, you know, sepsis, multi-organ failure. And the takeaway here is that there really was no clear relationship between either the presence or the severity of sensory dysfunction and their overall disease severity. And there's been some other studies in the literature that kind of show similar things. Probably the most significant of our results, though, is looking at the temporal relation of smell or taste dysfunction to other COVID symptoms. So this is a question of, you know, was smell or taste dysfunction their first COVID symptom and then subsequently they developed other symptoms? Was it their only COVID symptom? Or did it occur either at the same time or after they had other things such as, you know, cough, fever, etc.? Importantly, to our hypothesis that this might be an early warning sign, depending on the site, between 19 and 35% of the patients included had smell or taste dysfunction as either their first or only symptom of their COVID infection. So really, this does back up the idea that smell or taste dysfunction may be an earlier singular symptom of COVID infection. So those were, and then a few kind of other smaller takeaways from our study. Some of the patients did get some longitudinal follow-up. 77 of them were followed for up to 3 weeks after they first started showing improvement in their sense, or before they started showing smell or taste dysfunction. And at 3 weeks, 43% of them showed at least some improvement. And if you look in the literature, there's other studies that followed patients further out, and it does seem that the majority of these patients with smell and taste dysfunction do tend to get better over time. So it seems like whatever causing it is a more, causing some sort of temporary damage. That being said, there is a subset of patients who even several months out from initial infection still report smell or taste dysfunction. And for those patients, this can be a serious quality of life issue. So something will probably need to be done to try to help those patients better. And then finally, at one of the hospitals in Shanghai, all the patients, they screened all the patients, but any of the ones who didn't have any self-reported olfactory complaints actually underwent objective testing with a variety of kind of noxious odorants. And they found that 11% of those patients without subjective olfactory complaints nevertheless did show subclinical hyposmia on objective testing, which maybe indicates that for screening these patients, that while it is easiest just to ask them if they've had dysfunction, to really get a true sense of what's going on, we probably will need to use, you know, validated instruments and objective testing. And as I kind of alluded to earlier, as with any retrospective study, there's, you know, issues, especially when you're doing it at many sites internationally. So to truly validate these results, we do need to do, you know, more prospective work with objective sensory testing. And Dr. Levine will later kind of talk about the steps we're taking in that direction. So now that I'm done with our study, I'm just going to talk briefly about some other interesting studies from the literature. We're actually currently working on putting together a systematic review of both the clinical and basic science studies out there that deal with this issue, but I just want to highlight a few today. So first, we're obviously not the only group that's looked at incidence and prevalence of these dysfunctions. So there's a recent systematic review of the topic that I think brings up some interesting points for screening going forward. So first, just looking, they had included 10 studies, and just looking at olfactory dysfunction, they found that 53% of COVID patients had some, but depending on the study, it ranged from 5 to 98%, which is an enormous range. Likewise, gustatory dysfunction was found in 44% of patients, but again, huge range, 6% to 93%. So then they did something very interesting, which I think is the main takeaway from the study, which is that they divided the 10 studies into 2 subgroups for analysis. One of all the studies that only used unvalidated instruments, which is basically asking patients, did they have any subjective sensory deficits? And then the studies that used validated surveys or objective testing to evaluate patients. In the unvalidated group, only 37% of patients had anosmia, and with a confidence interval of 18 to 57%, so somewhat broad. In the study of patients that used validated instruments, 87% of patients had anosmia, so 2.5 times as many patients. And you can see here the confidence interval is much tighter. So it seems that, you know, only asking the patients themselves if they have any deficits is really kind of underestimating the prevalence of sensory dysfunction in COVID. And this actually kind of lines up with previous work in the sensory literature that just shows that, especially for patients with mild hyposmia, the patients really just are not very good at identifying their own smell deficits until they become, you know, more severe. And actually the rates of undiagnosed subclinical hyposmia are in the population are fairly high. So now that we've talked about just kind of general, you know, epidemiologic data about this, I want to talk about a few studies that have looked into how we can leverage this knowledge of smell and taste dysfunction clinically. This is a study from UCSD, which retrospectively evaluated 305 patients who presented with flu-like symptoms and subsequently had COVID testing. And they compared the COVID positive to the COVID negative patients. So they found that smell and taste loss had an incidence of 68 and 71% respectively in the COVID positive patients versus only 16 and 17% in COVID negative patients for an odds ratio of 10.9 and 10.2 compared to control. So it's interesting because one of the challenges of COVID is that, you know, a lot of patients just present with kind of a generalized flu-like illness. So cough, fevers, myalgia that are seen in a lot of other viral illnesses. So it seems that smell and taste dysfunction might actually be significantly more specific for COVID than a lot of these other associated symptoms, which obviously has implications for screening. So further extending the observation, 2 separate studies tried to create predictive models based on patient symptoms to see if they could predict whether or not patients, based on the symptoms, were positive for COVID. So one study looked at 302 COVID positive patients, or rather who underwent COVID testing, and the other looked at 803 healthcare workers who underwent COVID testing. And in both studies, they tried to create a logistic regression model based on symptoms. And in both of them, they found that the strongest individual predictor of variance was whether or not the patient had smell or taste change in one study or anosmia in the other one. And then both of them then tried to use the symptoms to create a receiver operator curve to look at, you know, sensitivity and specificity of these models in predicting COVID. So for those who aren't familiar, basically receiver operator curves are a way of evaluating the sensitivity and specificity of a test. And the important takeaway is the bigger the area under the curve here, the curve versus the line, which basically represents chance, the better the test is. So you can see here, in both models, they combined smell or taste change along with a variety of other predictive symptoms, so myalgia, fever, sore throat, etc. In this model, you can see on the left, you can see they used 5 different symptoms. The one on the right was actually interesting. They used 3 different symptoms, but they weighted smell more heavily compared to fever and myalgia. And the composite area on the curve was 0.83 and 0.78 respectively. You can see it corresponds to this area here. So basically, creating these predictive models, particularly leveraging smell or taste, can actually create a pretty effective screening measure. And, you know, this isn't going to replace using PCR testing to definitively diagnose the patients, but like Dr. Levine was saying, there is kind of a period where patients are infected and infectious, but are not yet going to test positive in PCR testing. And in that situation, this kind of model with a focus on smell or taste dysfunction seemed to actually be very effective potentially as a screening measure. So now that we're done talking about the clinical data, I'm going to talk a little bit about what we know about the basic science of how COVID may cause smell or taste dysfunction. And spoiler alert, the answer is not very much, but there are some interesting studies that I think people could build on to really further elucidate what's going on here. So a little bit of background. For the SARS-CoV-2 virus that causes COVID to invade a cell, it requires 2 proteins, ACE2 and TMPRSS2. So ACE2 is angiotensin converting enzyme 2 which physiologically is a negative regulator of the renin-angiotensin system. The main takeaway is that it's distributed throughout the body: lungs, respiratory epithelium, gut, heart, kidney, which likely provides a reason why the symptomology of COVID can cover, so many different manifestations. But really what's relevant to this talk here is it's also highly expressed in the respiratory epithelium of the nose and in the olfactory epithelium. TMPRSS2, which is transmembrane protease serine 2, its physiologic role is actually not well defined, but like ACE2, it's distributed throughout the body. And so SARS-CoV-2 has a spike protein, it's a glycoprotein on its shell that's necessary for facilitating entry into cells. But in order for that protein to become active, it has to be cleaved by a host protease, specifically this protease. So to enter cells, the virus requires both of these proteins to be present. So that brings us to some of the early research looking at smell and taste dysfunction. And I would just say that some of this research is from preprints that are still under review. So not all the research here has actually been peer reviewed yet, but I thought it was interesting enough that I wanted to present it regardless. So you can see in these diagrams here, all the different cell types that are present within the respiratory epithelium, olfactory epithelium, and olfactory bulb of the nose. Really the main takeaway here is that there are two really broad classes that are relevant to us. There's the neurons themselves in the olfactory epithelium and the bulb that are actually involved in the signal transduction of the odorants to your perception of a scent. And then a vast variety of different kind of what you can think of as supportive cells. So what these studies, which did both immunostaining and RNA-seq, found was that both of these proteins are highly expressed in the support cells in all three areas. So in the support cells of the respiratory lining, the olfactory lining, and the olfactory bulb. Conversely, they're not really expressed in the neurons, either the olfactory sensory neurons of the epithelium or the olfactory nerve itself. So the hypothesis here is that the anosmia associated with COVID might not actually be due to direct damage to the nerves itself, but rather due to damage to these non-neuronal support cells, as well as the immature stem cells that dwell in the olfactory niche and help replenish olfactory neurons as they're damaged over time. Interestingly, ACE2 is also expressed highly in the epithelial cells of the tongue, and ACE inhibitors, which are used for blood pressure control and affect the ACE receptors, are well known to cause as a side effect taste disturbances. So there is a potential that, in addition to this olfactory dysfunction causing taste perturbations as well, that the virus might actually be directly invading these cells on the tongue, causing taste dysfunction. However, this is all very preliminary. So that's basically the extent of looking at actual mechanisms of viral entry and perhaps of that might be causing the smell and taste dysfunction. However, there are a few interesting studies that have looked at other potential mediators in the smell and taste dysfunction that again are very preliminary, but I think could provide some interesting avenues for research. So first, age. As we kind of all know, old age is associated with worse outcomes in COVID. And there's a recent study that found that at least in mice, ACE2 and TMPRSS2 expression in the olfactory epithelium increases with age. So it's possible that you will see worse sensory symptoms in older patients, but again, that hasn't really been studied yet. Likewise, it's possible that genetics may play a role in which patients develop smell and taste dysfunctions and which ones don't. So the study that leveraged a twin database out of the UK that has thousands of both fraternal and identical twins in it, and cross-referenced that to twins who are used in mobile COVID symptom tracker to record their COVID statements. And they found that comparing the fraternal to identical twins, 40% of variability in the amount of anosmia reported by these patients could be traced to what they thought was genetic susceptibility. So this doesn't say anything about what these genetic factors might be, but it does seem to indicate that there is some role of genetics in which patients develop these symptoms. And then finally, as I talked about, that at different study sites in different countries, there are pretty widely varying ranges of sensory dysfunction reported. And obviously some of that might be study methodology, but it's also possible that could be differences in the virus itself. So there have been distinct variants of virus found worldwide, predominating in different areas. And there's been some new studies that have found there are actually different mutant strains with different spike protein structure that some people hypothesize might have different efficacy of infection. So it's possible that that could also be another mechanism that determines or helps determine rates of these dysfunction. So kind of the key takeaway points here are that from 2 months ago when we were just getting kind of anecdotal reports, I think we now can say pretty definitively that COVID infection is strongly associated with smell and taste dysfunction, and that smell or taste dysfunction may be an early or singular sign of disease, and that adding smell or taste evaluations to COVID screening can help increase their efficacy. Secondarily, the virus itself may directly infect olfactory support cells, leading to smell dysfunction. However, very little is actually known about the mechanistic, epidemiologic, and genetic factors that may influence these developments, so more studies are needed. And that's really the big takeaway here, and that's what Dr. Levine is going to be talking about next, is that prospective clinical studies, along with further basic and translational research are really kind of crucial for us to better understanding the association with these sensory dysfunctions. So with that, I will pass it back on to Dr. Levine.
Great. While I'm just sharing my screen here, I'll just remind people that we do have the question and answer section, and to ask questions as you go so that we can address them at the end or you don't forget. I saw a couple people utilizing that already, and hopefully some of those questions I'll be answering in this next upcoming set of slides. So I'm going to talk about how collaborative research can then really lead to our better research and better research understanding and our clinical applications. So really, how do we build on this information that we have? Well, obviously we need more research. That's always what every researcher says, right? We need more research. But we do need more research. We have the CTSI Rapid Response Grant that's going to facilitate a lot of the study, and also we applied for some NIH supplemental funding, hopefully to help increase the length that we can do these studies. We need retrospective data collection, not just retrospective data collection repeating what is already known within our own population, which is important because we do need to establish the baseline given that variability, but also looking for maybe other sensory deficits or sensory losses that haven't otherwise been detected because people haven't really been looking for them. We also need prospective data collection. As Dr. Nisenbaum was talking about, it's really important that we get some good prospective data collection to really further elucidate the findings that we found retrospectively, and then also the mechanism investigation. And so I'll talk a little bit about our plans for each of this. Also, clinical implementation. Smell and taste was added to the COVID-19 screening, and I think that's, as we've discussed, a very important piece for sensitivity and specificity, but also smell testing. And how do you do smell testing, or how do you get the instrument to do smell testing, and smell training, really to improve recovery. So I'll talk about that a little bit as well, especially for those who aren't familiar. And then clinical expansion. And I'll talk about a really exciting collaborative venture that we have coming up for a sensory clinic, which will be a great place for us to really look at some of this information further. So research in our retrospective data collection, we want to compare our Miami smell and taste loss experience to what's been published, right? We want to understand how our population compares to some of the other countries that we have good data on. And we're going to use that CTSI Rapid Response Grant to do it. And we also want to look at this retrospective review of our COVID-19 positive patients for a couple specific things. We want to assess the reported symptoms and screening question responses. So we have an idea of what our rate of smell and taste loss is that's being reported. That's really going to be a subjective measure, right? Not an objective measure. We want to evaluate other reported sensory losses. So if they're saying that they're dizzy, there's hearing loss, some of that has also been reported. We don't have good data on how common that is, if that's an association, if it's coincidental. So this is a way to look at that. And also we want to evaluate the impact of comorbid and demographic information, something that certainly, at least within our clinic, we collect pretty extensively and would allow us to get some better understanding. We see big variations in different countries. There may be big variations within different ethnicities, socioeconomic classes, et cetera, and we want to have an idea about that. And so that IRB is in submission. And on our prospective data collection, our goals for this is going to be first to establish establish the rate of subjective and objective sensory loss. So we're really trying to look at what is happening. We want to evaluate the temporal relationship to other symptoms. So when do these losses develop in relationship to maybe fever, cough, shortness of breath, and determine the longitudinal symptom recovery. What's the time frame? We know that for lots of viruses, that time frame of recovery may be in the first couple months, but there's a certain subset of patients for whom they may never recover, or that recovery can take up to a year, year and a half. So we want to have a better idea about that as well. Our target population for this group is going to be obviously COVID-19 positive patients, but we want them to be early in their diagnosis. So remember that we're trying to look at this idea of an early indicator or a marker for asymptomatic patients. So if I bring you back to that timeline that I started with in the beginning, and we think about the time of an infection to when the time of symptoms begin, I really would like to be getting patient information really in this early part as opposed to in this late part where it would be truly meaningful. So we want to find those patients in this early aspect where they're being diagnosed with the infection. And we know that just being diagnosed with the infection probably puts you somewhere over in here, based off of what I was telling you before. 3 days after your symptoms start is when you're most likely to be positive. So we know that we're going to be missing some of that early window. And if we want to ask about it, it needs to be relatively close to that time so there's no recall bias. We also want a large proportion of asymptomatic patients because we're interested in those asymptomatic patients and maybe some of the symptoms that they're noticing. So really the ideal population, and we don't have this yet, but I'm throwing it out there as maybe a suggestion that people want to help us work on, is asymptomatic surgery patients because they're undergoing routine pre-op COVID testing. This is something that we're doing for pretty much all of our surgery patients, definitely for all the ENT patients, but for many of the patients who are undergoing surgery. And we could easily add something like the CTSI consent to contact as part of the protocol for talking to those patients when they're being scheduled for their COVID testing to see if they'd be interested in being contacted about future research. So there are some potential areas for us to draw a larger number of patients than we already have, and I think that's something to explore. We also want to look at mechanism investigation. And so if you want to identify genetic variation associated with COVID-19 related smell disturbance, we really want to look at things that will be related. So we want to determine susceptibility, which may be influenced by that host genotype. And the population here is going to be COVID-19 positive patients. These are patients that would have well-characterized objective smell disturbance, so something that has been objectively tested. And the methods are really going to be whole exome sequencing. So if you look at the schematic in the bottom over here, you remember that the exons are that small portion of the genome that actually encode the proteins. And so we're really looking at those pieces that are going to form those different proteins. And we want to assess different genes or exons that are highly expressed in nasal epithelium, determine if the gene variants are associated with the anosmia or hyposmia, so smell loss. And we want to look at some of those proteins that Dr. Nisenbaum was already talking about, so the ACE2 and the TMPRSS and also innate immunity genes as well, to give us a better idea of maybe some of these associations. And so that is work that's in the process of being developed and applied for, and is certainly going to be something that could be very interesting. So then I want to talk just a small amount about clinical implementation. So the COVID-19 screening, we talked about adding the smell and taste questions, and Dr. Nisenbaum really discussed why that increases your sensitivity and specificity and is a really good potential. And I've shown here the smell identification test. And so if you want to look at this online, this is a test that we order in our clinic and we can give to patients. And it's something that other people can order in their clinics as well. And it's something that we would be happy to share what it is, but it's the Pennsylvania UPSIT or smell identification test. And this is an objective, basically scratch and sniff test. You scratch the little thing off like you did when you were a kid with one of those little scratch and sniff books. And you'll say if it smells like gasoline or bubble gum or like a skunk, and you fill out the multiple choice test, and there are 4 booklets, and then you either send it back or we score it in person. And that gives us an objective measure. But not every patient needs to come in for an objective measure if they subjectively can tell you that they have smell loss. And so one thing that's really worth considering is something called smell training. Smell training, which I'm showing here with just some of the oral essence oils, is really the idea that you're basically practicing the use of those neuronal connections. So I always talk to patients about saying, well, if you were going to trying to get better at basketball and shooting a basket, you'd go out and practice because you want to really practice that movement. You want to have the muscle memory and the nerve memory to be able to do this properly. Same thing is going on with the idea with scent training and smell. You're choosing 4 scents. I usually tell people to choose essential oils, and I counsel them that they should not choose anything that would be caustic in any way. And I tell them that they should then smell those hopefully a couple times a day, and usually twice a day. And then I tell them to do it for about 3 months. And studies have shown that that really does make an improvement in their results and people's recovery. So now I'm going to move on to clinical expansion. This is talking a little bit about sensory dysfunction and the idea that sensory dysfunction is important beyond COVID-19. And I'm just going to briefly go through this. The idea that something such as smell disturbance, as an example, is really linked to many other diseases as an early indicator. It's an early indicator for neurodegenerative diseases like Parkinson's and Alzheimer's. It has links to aging, and in patients can be associated with the 5-year mortality. People with smell loss had a much higher 5-year mortality than those who didn't in some studies. And also is linked with other diseases, things like depression, some of the autoimmune diseases such as lupus and Sjogren's. So there are a lot of reasons why this is a good area for research. And so if we want to develop a sensory clinic, this is something that we're well poised to do. The University of Miami ENT department has been ranked 9th in the US World News and Report. Since 2012 to the present, we've been in the top 17 ENT departments and NIH funding with multiple types of grants and multiple types of research ongoing. We've expanded our research training. As you heard Dr. Nisenbaum talking, he's one of our T32 residents, and then we've added that for our research training, as well as mentored surgeon scientists, myself, Dr. Din. There are several members of the department who are training research surgeon scientists. And then also we've hired some new faculty. Dr. Acosta, who is just going to be starting, she has a background in clinical rhinology and interest in allergy and smell, and so she's really going to be a point person for this sensory clinic. And then our Vice Chair of Research and Program Director, Dr. Liu, who's one of the top 5 NIH-funded otolaryngology surgeon scientists in the country. Additionally, we've really worked to expand our interdisciplinary collaborations to make this something that can come to fruition. We are co-hosting the 2021 Miami Winter Symposium on Molecular Neuroscience that's focusing on sensory disorders. We're doing the collaborative study identifying early markers of cognitive loss and sensory impairments, and we've been working on evaluating those relationships. And also the sensory disorders in COVID-19 that we've talked about today. So if you think about our sensory clinic kind of as a big umbrella, this is really the melding of smell and taste in the rhinology and the skull-based division with hearing and balance in the neuro-otology division. And Dr. Liu is really the director of this clinic, and there's a whole bunch of faculty, both clinical, research, audiology faculty who would be involved in this process, as well as a bunch of collaborations with different departments in different areas. So obviously research and training, Dr. Nisenbaum is one of these people, our Center for Cognitive and Neuroscience and Aging, Learning and Memory and Aging, also the Hussman Institute for Human Genetics, our Bascom Palmer Eye Institute, infectious diseases, public health sciences, and of course physiology and biophysics for some of our more research-based things to really come together and collaborate on this endeavor. So I think this is something that could be really promising, and we're hoping to get this started early this summer, and we're looking forward to working with you guys on it. So we'll start taking questions. I have included my lab mates, or I guess my workmates here, representing the different areas that we're going to be doing in our sensory clinic, since my dogs help me with every presentation that I do.
Great, thank you very much. This was terrific, and it really does show, I think, the power of collaboration as well with the multiple different disciplines that you've established to work on the sensory clinic. Really terrific work. There are a number of questions, and some of them deal with how we test, what does it mean, timing, and then also obviously some on treatment. So maybe first a little bit about how we test. You made it clear that you can have these smell cards, and I know neurologists sometimes will have things in their bag that include coffee and other things to smell, but the smell test is a more standardized approach. Dr. Nisenbaum, when you showed the data from Germany and China, that data, they didn't use any objective testing in those studies.
So it's the data, being a retrospective review is kind of all over the place. So every center did just subjectively ask. Some of them did also, in addition, use some of the validated studies. So like the smell disorder validated instruments that Dr. Levine was talking about, some visual analog scales of smell and taste. And then one of the Chinese hospitals also did some objective smell testing. It wasn't like the validated upset. It was more like you were talking about, like with like a neurologist's office. Like they gave patients 3 different scents to smell and see if they could identify it, which is kind of like a quick and dirty way of doing it. So there was a little bit of objective testing, but yeah, I agree that there is definitely a way to do it in a more standardized, better validated fashion.
And in your pilot study and the work you want to do, Dr. Levine, are you going to do it? I mean, you mentioned, I think, doing it a number of ways and all can be done remotely. What do you think about the best approach for evaluating smell in these studies?
So the ideal is going to be to do testing and to really be doing it with these little upset booklets. So each booklet kind of has 10 questions. There's 4 booklets. It's 40 questions to evaluate it. And I can tell you that at least in my research study, I have a prospective research study, and what we've done for COVID is we're now mailing that already out to our patients, and they're mailing it back, and then we're letting it sit for a while and then handling it with gloves to do the evaluation. Obviously, we need to be smart about this. So I think that's certainly a reasonable thing that can be done in the event that it's going to change clinical care. I do think that testing is important. I think that the reality is that, you know, to give everybody a 40-question scratch and sniff test is probably not the easiest way to do pre-screening. Something more like the, you know, 3 different scents. If you have 3 essential oils in your clinic, that may be a reasonable option, or to have patients do that at home as a screening test to say, oh yeah, I can't smell these things. And that may be a good kind of objective way to say, now it's worth doing some additional testing. But certainly that's something that there's the ideal and then there's the practicality of it.
So even if you can send the test, so like you said, send in the mail, you could send it and then they can send it back. Another way would be to send them the test or the smell card, and then they enter something on the computer. But are there other ways where they could enter stuff in an app or via text or other approaches, even by phone, to answer the question? So I mean,
I think that there's, you know, one easy way to try to enter data that we're doing for other things is to do REDCap survey.
Okay.
Part of it is that, you know, of course, there are 40 questions. So 40 questions and your possible rate of error and people's interest in doing that decreases. For our motivated people, I think that that would be a reasonable option. The other option is really to have them open the book and take a picture of their answers and send it back to us. Right. Which to me makes the most sense, because these are, I don't know how you say it, but they're basically staggered. So you could actually see all of the answers all together. And if they took pictures and just sent it either by email or some other secure way, I think that actually would be the easiest. We've started trying to see if we could do that, but the secure feature is what we're gonna have to work on. Maybe there's a way to upload it into UChart.
There's an interesting question here about whether this kind of testing, you know, with further data and validation, and could this ever be used in, you know, how they're trying to screen for fevers when people come into airports and everything, or public facilities? Would there ever be a way that you could do this in a mass way for testing in a large public event?
I think that probably something closer to what Dr. Nisenbaum was talking about with the, you know, couple different scents to try to be able to identify those things would be a reasonable way to do it. One of the challenges is that you never know what people's pre-existing smell loss was. As Dr. Nisenbaum very nicely pointed out, the rate of hyposmia, or partial smell loss, that exists in the normal population is pretty high. People just don't usually get evaluated and they don't really notice. And so we may, if we have something that's really too sensitive, we may be inaccurately giving false positives away, which we don't want to do either.
True. So Dr. Nisenbaum, you mentioned that in the you know, the retrospective studies or the studies where they didn't do standardized testing across, 43% improved at 3 weeks, while 57% didn't. And there are some questions here about, you know, what do you think, and maybe your study will show this, about the likelihood of improvement, maybe in the longer term, beyond 3 weeks. And then as a follow-up to that, for people that have continued smell problems, what do we do therapeutically?
Yeah, so I mean, I think the answer to that question will ultimately come down to, in part, what we figure out mechanistically about what the actual mechanism of damage is. I mean, at the most simple, like say some of the smell loss was what we call conductive, which is that these patients are also having just having swelling of the mucosa within their nose and just blocking odorants from getting to the olfactory. So that would be the most quickly resolved, you'd imagine. I think that if it's damaging support cells but not neurons or just the stem cells, maybe that would last somewhat longer, even if it's, but maybe would still come back. If it's directly damaging the nerve and like the olfactory bulbs, maybe then that smell loss will be more permanent. But again, it's hard to say without having a good understanding of, is it caused, the smell is caused by direct invasion of cells? Is it caused by a more generalized inflammatory response that's then causing like secondary damage? Just, I think right now it's kind of hard to say.
The etiology could determine. But Dr. Levine, what do you do with somebody then who has persistent smell loss therapeutically?
So I think the first thing is that, let's say that they're kind of at the point where this is starting, I think that the smell training is something you can do remotely and discuss with them without ever having to see them in clinic, especially if they're positive and they're worried about their recovery. And it's something that anyone can do. You can order essential oils off of Amazon or from your local store and they'll get it delivered at this point. So you'll be able to do some of those things. I think that if it persists, you want to rule out that they're having another problem. So you want to rule out that it's a nasal obstruction problem. We do know that sometimes viruses can drive people developing a more chronic nasal obstruction. So we want to examine and evaluate for that. Many primary care providers will sometimes prescribe Flonase or fluticasone, which is a nasal steroid spray to reduce swelling. Another reasonable thing to start with before maybe they see an ENT. And then they get evaluated to see if they're having nasal obstruction. And if that appears to be a lot of the cause, we treat that cause. Then, if that is not part of it, then the next thing, with smell loss is really to make sure that there's nothing else more serious going on. As you maybe have seen from our diagrams, the smell nerve does run along the base of the brain intracranially. So we don't want to make sure that people aren't having tumors or other things. Sometimes that can also be a presentation with smell loss. And then after that, really, if it's a loss that's been going on for a certain amount of time, other than the smell training, at this point, there aren't a lot of great studies to show other things that we can do other than waiting to see if people recover their sense of smell. But there are some, pretty minimal side effect things that we can do, such as rinses that have steroid in them or a few other things that we can try for patients who really want to try to do something additional. So there are some things that we can talk about, and that's really a great way to use that sensory clinic, is to have the option to sit down and go through the objective testing, the subjective component, how it's impacting their life, and what's going to be worth trying for those patients.
That's right. Yeah, it's obviously multifactorial, and looking for both obstructive or viral affected or even neurological relationships for the cause of the smell loss would be important. Any ideas yet from the data, the early data, about ACE inhibitors and whether they have any relationship with developing the smell loss or worsening? Anybody know that? Any ideas?
I don't think that we have seen any data on that. None of the people that I've talked to, I'm on a forum of rhinologists who kind of go back and forth about a bunch of different things, have really discussed it. I do think that there are people who are already underway and trying to get that set up or very early getting data, but I don't think that, unfortunately, we have very much yet about whether or not that is impacting the smell loss or changing the timeline of what's happening.
And there's a very good question, obviously, from one of our taste experts. As you know, we have great taste experts here. Any way to separate this out? You made it clear that smell is related to taste, but then some people have both. But what about doing validated studies of taste? Is that incorporated in any of your studies or others? Either of you? So
we have an objective way to evaluate taste. And as I was explaining, it's a pretty long process. It is not something you can really do in a standard clinic because it takes about 20 minutes. It's about 20 different taste strips that you have to apply, and you really need to know what order you're applying them in because they all look the same. And so that part of the process is something that I think we're hoping to incorporate within our sensory clinic and within some of our research, especially for those patients who say that they have persistence of taste loss. I think objective testing is going to be a reasonable thing. And as we get better at doing it, and hopefully there might be better ways to do it faster, this may be something we can incorporate into a routine clinical practice. I think at this point, it's probably a very specialized opportunity. It's not something that you could just do, you know, anytime or really mail out to somebody.
Well, some of your expert collaborators out there, as you know, and you listed on their slide, have some special tests, including a jelly bean test that they're talking about that could be utilized. So it is something to be thinking about, since obviously there is this relationship with taste and smell, and trying to objectively pull it apart. There's some great comments going back and forth regarding that, and cinnamon and apple jelly beans. So I urge you to consider them. I also wanted to end a little bit question about the genetics. You raised the genetic. We saw some heterogeneity across your even retrospective studies with Germany. And that may have a clue here in terms of kind of a genetic behavioral interaction. And you are going to be looking at some genetic testing as well, it sounds like. Is that right?
Yeah, and that's, I mean, it's something we discussed a little bit in our paper. So there were some differences in between the German and French groups, but the differences were much more significant between the Chinese group and the French group, and the Chinese group and the German group. So there is, again, that question, like, is that because of virus strain, or does it more reflect like greater population-based differences in genetics? And luckily, we do have, from our previous, particularly our previous like, deafness research, genetics of deafness, a lot of different populations we've looked at. Like we've looked at it in Miami in the Hispanic population. We've looked at the Chinese population. So we kind of have the resources and expertise already set up to kind of apply that to smell.
Key is Save the Blood and DNA or Buffy Coat, and obviously our genetic experts are there to help. So really terrific presentation. It shows, again, the power of collaboration, the great idea of early testing, but it goes off into so many different directions, as you say, with your sensory clinic. So first of all, thank you, both of you, for sharing these early observations and your work in progress. We have a couple questions listed for our audience there. Did the seminar meet your expectations for this COVID-19 topic? And do you plan to attend future ones? As you know, we have a faculty council meeting. That's why we're at 4 o'clock today. And we will probably stop trying to interfere with the faculty council and be sticking to 5 o'clock in June when we have these Translational Tuesdays. Thank you both for sharing your information with us, and really good luck with this fantastic project. Thank you.
Thank you.